skin as just the packaging.
Yeah, the wrapper.
The wrapper that keeps the inside world in and the outside world out.
Exactly. And we agonize over wrinkles or, getting a tan. But when you actually read through the source material for today, which is chapter 47, skin and soft tissue infections, you realize it is so much more than a wrapper. It's a fortress.
It really is.
It's an active, aggressive immune organ that is constantly under siege. And today's mission is to figure out what happens when that fortress is breached.
We are looking at, at biological warfare. The text covers the full spectrum, from the minor skirmishes, like that annoying rash your kid picks up at daycare,
Right.
all the way to the, let's call them the nuclear options, the limb-threatening emergencies that require you to be on an operating table within the hour.
And what I found most valuable in this text is the decision-making framework. It's not just a list of diseases, it's a decision tree.
Ah.
How does a doctor look at a red patch on a leg and decide, okay, this needs a simple cream, versus...
we need to cut this open right now.
Exactly. That's the code we're cracking today.
And that distinction is really the core of the chapter. It's about recognizing patterns. And it usually starts with identifying the enemy. The text makes it clear that while there are thousands of bacteria out there, when it comes to skin infections, we are usually dealing with the big two.
The usual suspects: Staphylococcus aureus and Streptococcus pyogenes.
Staph and strep. I mean, if you are a betting person and you bet on one of these two being the culprit for a skin infection, you'd win the vast majority of the time.
So they're the dominant pathogens.
They are, and for a reason. They have evolved specifically to thrive on human skin and, well, to exploit our weaknesses.
But the text flags a shifting dynamic here, specifically with staph. It mentions the rise of CA-MRSA. I think most people know MRSA is the scary hospital bug.
The one you get after surgery.
Right, the one you get after a knee replacement if you're unlucky. But the CA part changes the equation completely, doesn't it?
Fundamentally. I mean, for decades, MRSA, methicillin-resistant Staphylococcus aureus, was a nosocomial pathogen. That's fancy medical speak for it lived in hospitals and nursing homes.
So if you were young, healthy, and hadn't been near a hospital, you didn't really worry about it.
You didn't. You worried about regular, treatable staph.
But community-associated, or CA-MRSA, means this resistant superbug has. It's escaped the lab, so to speak. It's now circulating in locker rooms, schools, households.
Gyms. Exactly. So the old rule of I haven't been to a hospital so I can't have a resistant infection is dead. The text emphasizes that the strain is virulent and it affects healthy people.
And that complicates everything. The first line of defense, the standard antibiotics, the penicillins we used to hand out, they just bounce right off these community strains.
It's like the bacteria upgraded their armor while we weren't looking.
So before we get into the specific battles and the specific diseases, let's look at the map. The text offers a classification framework to help us understand how these infections take root. It splits them into primary and secondary infections. This seemed like a crucial distinction.
It is. It's really about understanding the terrain of the illness. Think of a primary infection as a targeted strike on generally healthy territory.
Okay, so you have normal, intact skin.
Exactly. And a single specific bacterial species manages to breach the walls.
So one bug, one problem, a solo invader.
Precisely. Things like impetigo or erysipelas fit here. The skin wasn't damaged beforehand, the bacteria was just aggressive enough, or the conditions were just right for it to get in.
Versus a secondary infection, which the text describes as more opportunistic. This is where the wall was already down.
Right. Secondary infections happen because the defense is compromised. Maybe you have a surgical wound, a burn, a diabetic ulcer, or even just a bug bite that you've scratched open.
The door's already ajar.
Door is ajar, and because of that, you rarely find just one type of bacteria entering.
The text uses the term polymicrobic.
Which is exactly what it sounds like. It's a microbial zoo. You might have staph, strep, and maybe some gram-negative bacteria or anaerobes all colonizing the same wound.
Which makes treatment much, much harder.
Much harder. You can't just target one specific organism with a sniper rifle. You need a shotgun approach.
Now, even with these bugs around, and we know staph and strep are probably on my skin right now, we aren't infected all the time. The text lists a recipe for infection. It argues that just having bacteria on your skin isn't enough.
You need a specific alignment of factors. It's a perfect storm.
Okay, what are the ingredients?
Well, the text identifies 5 key ingredients for this recipe. First, obviously, a high concentration of bacteria. If you have a massive bacterial load, it's harder for your immune system to fight off the initial invasion.
It's a numbers game.
It's a numbers game. Second is excessive moisture.
Which weakens the skin barrier. I always think of how your skin looks after a long bath, prune, soft, fragile.
Exactly. That is maceration. It disrupts the integrity of the cells. Third is inadequate blood supply.
So the troops can't get to the battlefield.
Your white blood cells, your soldiers, can't get there to fight. Fourth is the availability of nutrients for the bacteria. And fifth, and this is the most critical one, is damage to the corneal layer.
The outer shield, the stratum corneum.
Right, so if you have a cut, that's damage. It's a hot, humid day, that's moisture, and you're in a dirty environment, high bacteria count, you have successfully cooked up an infection.
Let's apply this framework to the actual diseases. We'll start on the surface level with the primary infections. And the first one is, well, it's a rite of passage for many parents, and honestly, it's just unpleasant to look at. Impetigo.
The classic crusty infection.
The text highlights that this is incredibly communicable, spreading through daycares and schools like wildfire. But it points out that the spread is largely behavioral.
It's not just floating in the air, no. It's mechanical. The medical term is pruritus, which means itching. Impetigo itches intensely.
So kids scratch it.
They scratch the lesions, getting the bacteria, usually S. aureus or S. pyogenes, under their fingernails. Then they touch another part of their face, or they touch a toy that another kid touches.
It's auto-inoculation. You are literally planting the infection in new places on yourself.
Exactly. And visually, it's very distinct. The text describes the non-bullous type, which is the most common. It starts as small, fluid-filled vesicles, these tiny little blisters that burst.
And what happens when they burst?
When that discharge dries, it forms these hallmark golden yellow crusts.
Almost like honey dried on the skin. I've heard it described as looking like cornflakes stuck to the face.
That's a perfect description, and that's the visual cue doctors look for. If you see honey-colored crusts on a kid's face, it's impetigo until proven otherwise.
Is there another type?
There is a bullous type where the blisters get much larger and leave a thin brown crust, but that golden crust is the signature.
Okay, treatment-wise, I was interested to see that we don't always need to go to oral antibiotics. The text suggests that for localized cases, topical treatment is actually just as good.
That's a big win for antibiotic stewardship. Mupirocin ointment is very effective. If you catch it early and it's just a few spots, you don't need to nuke the whole body with penicillin.
But if it spreads?
If it spreads or if there are multiple outbreaks, you do move to oral therapy. And here's where that bacterial identification matters. Simple penicillin works for strep, but remember, staph is also a major player here.
And staph produces an enzyme called penicillinase.
It eats the penicillin. It just deactivates it. So if you prescribe regular penicillin for impetigo, and it's caused by staph, you're essentially giving the bacteria a drink of water. It won't do anything.
So you need a penicillinase-resistant penicillin, like dicloxacillin or cephalosporin. You have to anticipate the resistance.
Correct. You have to assume the armor is there.
Moving just a little deeper into the tissue, we find a condition with a very dramatic, almost medieval name, St. Anthony's fire.
Clinically known as erysipelas.
Why the fire reference? Is it just the color?
It's the heat and the color. Erysipelas presents as a bright, fiery red rash that is intensely painful and warm to the touch. Unlike impetigo, which sits right on top, this involves the superficial layers of the skin, but also specifically the cutaneous lymphatics.
Ah, so that lymphatic involvement seems to be the key to the symptoms.
Yeah.
The text mentions lymphatic streaking.
Right. You can sometimes see these red streaks running from the rash towards the lymph nodes. But the biggest differentiator, the way you tell this apart from other rashes, is the margins.
This is the cliff edge concept you hear about.
Yes. Erysipelas has clearly demarcated raised margins. If you closed your eyes and ran your finger over the rash, you would feel a step up where the infection begins. It's like a plateau on the skin.
This is a very clear border.
Very clear. That is distinct from cellulitis, which we'll talk about next, where the redness just kind of fades out into pink and then normal skin.
Another fascinating diagnostic clue the text mentions is the timing of symptoms. With erysipelas, you often feel sick before you look sick.
That's the prodrome. Patients report fever, malaise, chills, classic flu symptoms, sometimes hours before the red rash actually appears.
So what's happening there?
It's a systemic warning bell that the strep bacteria, it's almost always group A strep in this case, are releasing toxins into your system before the local damage is even visible.
Okay, so if erysipelas is the superficial layer with the sharp border, let's go deeper. Let's talk about cellulitis. This seems to be the bread and butter skin infection for adult medicine. I feel like everyone knows someone who has had cellulitis.
It is the most common serious skin infection. Here, the bacteria have invaded deeper into the dermis and the superficial fascia, and because it's deeper, you lose that sharp border we just talked about.
The margins are poorly defined.
Poorly defined. It's the spreader.
The spreader, I like that.
It's red, which is erythema, it's swollen, which is edema, and it's painful. And because it's draining into the lymphatic system, you often get tender lymphadenopathy, swollen lymph nodes in the groin or armpit, depending on where the infection is.
Now, the text brings up a really counterintuitive point about diagnosing cellulitis. Logic suggests that if you have a bacterial infection in the skin, you should be able to stick a needle in it, get a sample, and identify the bug. But the text says that usually fails.
It's incredibly frustrating for clinicians. The yield on needle aspiration or biopsy of the leading edge of the rash is notoriously low. It often comes back negative.
Why is that? I mean, is the bacteria not actually there?
Oh, it is, but the density might be low. Or the redness might just be an immune reaction to toxins released by bacteria that are actually sitting further back in the center of the infection.
So you can't always catch the culprit in the act at the front lines.
You can't. So doctors are essentially flying, well, not blind, but they are flying on instruments. They rely on empiric therapy.
Educated guessing.
Educated guessing based on the patient's history. Did they have a trauma? Do they have a history of ulcers? Are they an injection drug user?
The text specifically highlights injection drug users as a high-risk demographic for cellulitis.
It's a massive risk factor. You are bypassing the skin barrier entirely with a needle. And in that population, the incidence of MRSA is extremely high. So if a patient comes in with cellulitis and a history of IV drug use, you don't wait for a culture. You assume it's MRSA immediately and treat aggressively.
Let's ratchet up the severity. We've gone from crusty skin to deep red swelling. Now we reach the level of a surgical emergency. The text shifts tone here to discuss necrotizing fasciitis.
The flesh-eating bacteria. This is where minutes matter. Necrotizing fasciitis is an infection of the deep fascia.
The connective tissue layers that hold your muscles together.
Right, and it results in the rapid death of that tissue.
The mechanism here is terrifying. It's not just that the bacteria are eating the tissue, they are destroying the supply lines.
Correct, that's why it moves so fast. The bacteria produce toxins that cause thrombosis clotting in the blood vessels feeding the skin and fascia. They cut off the blood supply,
which causes the tissue to die.
The tissue dies necrosis, and it turns black.
And this explains why antibiotics alone fail. I think that's a hard concept for people to grasp. Why can't we just give stronger drugs?
It's a logistics problem. Antibiotics travel through the blood. If the infection has destroyed the blood vessels, the delivery truck can't reach the house. You can pump a patient full of vancomycin, but it will never reach the dead tissue where the bacteria are thriving.
So the only option is the knife.
Radical surgical debridement. You have to cut. And you keep cutting away the dead, gray, non-bleeding tissue until you hit healthy, red, bleeding tissue. It can be disfiguring, but it is the only way to stop the spread.
You have to physically remove the factory producing the toxins.
That's the only way.
The text breaks this down into types in Table 47-1. I didn't realize flesh-eating bacteria wasn't just one specific bug. I thought it was a single monster.
No, it's a category of clinical destruction, not a single species. Type I is actually the most common, and it's polymicrobic, that mix of anaerobes and facultative bacteria we talked about.
Often seen in post-surgical patients or diabetics.
Exactly. Type 2 is the classic one, caused by group A strep, the same bug as strep throat or erysipelas, just behaving much more aggressively.
It's amazing that the same bacteria that causes a sore throat can essentially dissolve your leg if it gets into the fascia.
It really speaks to the power of the environment and the immune response. And then you have type 3, which is gas gangrene caused by Clostridium perfringens. It actually produces gas in the tissues.
And that type I, being polymicrobic, that connects back to our classification of primary versus secondary. It sounds like a secondary invasion of compromised tissue.
Precisely. It's the wall falling down and the whole horde rushing in.
Speaking of compromised tissue, the text dedicates a significant section to the complicated cases, specifically diabetic foot infections. It calls this a silent threat.
It's silent because the patient literally cannot hear the body screaming.
The triad of causes.
Yes. To understand a diabetic foot infection, you have to understand the 3 failures happening simultaneously. First, neuropathy. High blood sugar over time damages the peripheral nerves. Patients lose sensation. They call it loss of protective sensation.
So they could step on a tack or have a shoe rubbing a hole in their toe and they feel absolutely nothing.
Nothing. No signal goes to the brain. That is why they usually come to the doctor, because they see something. Hey, doc, my sock is wet with pus. Not because they feel pain.
That delay is catastrophic.
It is. By the time they see it, the infection is deep. Second is ischemia.
Poor blood flow.
Right. Diabetes damages the blood vessels, so the healing factors, oxygen, antibiotics, white blood cells, can't get to the wound efficiently.
And third is immunologic defects. Even if white blood cells get there, they don't function as well in a high-sugar environment. They're sluggish.
So you have a wound you can't feel, receiving no blood, defended by a sleepy immune system. It's the perfect setup for a severe infection.
The text mentions a diagnostic tool here that is visceral, the smell test.
It's low-tech, but high value. If a wound has a foul, putrid odor, it tells you immediately that there are anaerobic organisms present.
And why is that significant?
Anaerobes thrive in environments without oxygen-like deep, dead tissue, and they produce metabolic byproducts that smell terrible. So that smell tells you the tissue is dying.
And the risk here isn't just losing skin, it's the bone.
Osteomyelitis. Because the skin on the foot is so thin, the infection easily travels down to the bone. The text notes that 30% to 40% of these infections involve the bone.
And once it's in the bone.
Curing it with just antibiotics is incredibly difficult. That's why amputation becomes a real and frequent risk.
The goal is limb preservation, but it requires aggressive management. The other major category of complicated wounds is pressure ulcers or bed sores.
A massive issue in nursing homes and ICUs. This is purely a physics problem. It's about forces. The text lists 4: pressure, shearing, friction, and moisture. When a patient lies in one position, the weight of their body presses the skin against the mattress, usually over a bony prominence like the tailbone or the sacrum, heels, hips.
It squeezes the blood out of the tissue, like stepping on a hose.
Exactly. And if that pressure exceeds the capillary filling pressure for too long, the tissue starves and dies.
The text emphasizes that prevention is the only real strategy here. Once they start, they are a nightmare to stop.
Prevention is everything. The text cites that relieving pressure for as little as 5 minutes every 2 hours can be enough to prevent them. It's such a small intervention turning a patient, but it saves lives.
There's a staging system mentioned from 1 to 4, and I want to clarify stage 1 because it sounds subtle, but it's the most important one to catch. Non-blanchable redness. What does that mean to a layperson?
Okay, try this. If you have a normal rash, like a mild sunburn, and you press your thumb on it, the skin turns white for a second, right? Then the blood rushes back and it turns red again.
That's blanching.
That is blanching. It means the microcirculation is still intact. The plumbing works.
Okay, I'm doing it on my arm right now. Press down, white spot, fades back to pink. Normal.
In a stage 1 pressure ulcer, if you press on that red spot, it stays red. It does not turn white. That means the damage has already occurred to the microvasculature. The tissue is in distress.
That's the warning sign.
That is the red light. If you see that, you have to get pressure off that spot immediately.
And if you miss that, it progresses to stage 2, a blister or open sore. Stage 3 goes down to the fat. And stage 4.
Exposed bone, tendon, or muscle. At stage 4, you're almost certainly dealing with osteomyelitis as well. It's a deep, open crater.
There's also a category called unstageable, which sounds mysterious.
It's not mysterious, just obscured. That's when the wound is covered in slough, which is this yellow or green goop, or eschar, which is dead, hardened black tissue.
You can't see how deep it is.
You literally can't tell how deep the hole is because it's filled with debris. You can't stage it until you debride it, clean it out. Could be a stage 3, could be stage 4. You won't know until you dig.
Let's shift gears from stationary injuries to dynamic ones. Bite wounds. The text covers the trinity. Dogs, cats, and humans.
And they each have a unique microbiological fingerprint.
Let's start with dogs. Man's best friend, but maybe not when they bite you.
Dogs have powerful jaws. They don't just cut, they crush. So a dog bite is usually a crush injury combined with a tear. The tissue is traumatized, which makes it easier for bacteria to take hold. The text mentions an 8-hour rule here.
Meaning?
If you get bitten and wait more than 8 hours to seek medical attention, the infection risk skyrockets. The bacteria have had too much of a head start.
Is there a specific bug we worry about with dogs?
Pasteurella multisida is the big one. If that gets in, cellulitis can develop very fast within 24 hours. But generally, dog bites are messy but often open, which allows some drainage.
Unlike cats, the text seems to imply that cats are actually more dangerous in terms of infection risk.
They are. About 20% of cat bites get infected, which is a higher rate than dogs.
Why is that? Is their mouth dirtier?
Not necessarily dirtier, but the delivery system is more efficient for infection. First, Pasteurella multicida is found in the mouths of 50 to 70% of healthy cats. So it's almost guaranteed to be there.
Okay.
But more importantly, cat teeth are like hypodermic needles.
They don't tear, they puncture.
Right. They inject the bacteria deep into the tissue, and because the puncture hole is tiny, it seals over quickly. You can't wash it out easily. So you have a sealed pocket of bacteria deep in the hand or arm.
It's the perfect abscess starter kit.
It really is.
And finally, humans. We have surprisingly dirty mouths.
We really do. The infection rate for human bites is anywhere from 10 to 50%. Our mouths are a complex ecosystem of aerobic and anaerobic bacteria.
The text highlights a specific injury pattern, the clenched fist injury. This is the one that really stuck with me.
The classic bar fight injury. Someone punches someone else in the mouth. The victim's teeth shatter the skin over the puncher's knuckles.
So the puncher is actually the one at risk of infection. He thinks he won the fight, but he might lose his hand.
High risk. The knuckle joint capsule, the space inside your knuckle, is very superficial. The teeth can penetrate right into the joint space, introducing a bacteria called Eikenella corrodens. It's a classic fight-bite pathogen.
And if that sets up in the joint,
it can destroy the cartilage and function of the hand permanently.
And there is a golden rule for managing human bites mentioned in the text, something you should never do.
Never do a primary closure. Never stitch a human bite wound shut immediately.
Because you're sealing the bacteria inside.
Exactly. If you stitch it, you are creating a warm, moist, anaerobic incubator. It is a guaranteed abscess. You have to leave it open to drain, wash it out aggressively, and maybe do a delayed closure later once you know it's clean.
That is a crucial takeaway. If I ever get into a fist fight, I'll remember to leave the wound open.
Or just irrigate it. Irrigation is the most important step for all bites. Dilution is the solution to pollution. Wash it out.
So we've covered the battlefield and the enemies. Let's talk about the weapons. Treatment strategies. You mentioned empiric therapy earlier, guessing the drug before you know the bug. How do doctors make that guess educated? It can't just be random.
It's not. The text gives a very simple heuristic. A rule of thumb based on one thing. Puss.
Puss versus no puss. That's it.
That's the fork in the road. Purulent versus non-purulent. If the infection is purulent, meaning there is an abscess, drainage, or visible pus, you have to assume the cause is Staph aureus, specifically MRSA.
Because staph makes pus.
It's pyogenic. It attracts neutrophils, those white blood cells, which die and form pus. So if you see pus, you prescribe drugs that target MRSA. Trimethoprim sulfamethoxazole, which is Bactrim, doxycycline, or clindamycin. You need coverage for that specific bug.
And if it's non-purulent, just a red-hot swollen leg without a boil.
Then the probability shifts to strep, the beta-hemolytic streptococci. Strep tends to cause that spreading redness cellulitis or erysipelas without the localized pus pocket. For that, beta-lactams like cephalexin or penicillin are still the champion.
So puss equals staph meds. No puss equals strep meds.
Generally speaking, yes. That's the starting point before you get lab results.
What about when we have to bring out the big guns for staph, like vancomycin? This is usually IV, right? The text mentions something about trough levels. That sounds technical, but why does it matter to the patient?
It matters because dosing vancomycin is a tightrope walk. It has a narrow therapeutic index. You have to monitor the amount of drug in the blood, the trough level, right before the next dose is due.
If it's too high.
You risk damaging the kidneys or causing hearing loss. It's toxic.
And if it's too low.
This is the dangerous part. If it's too low, you don't kill a bacteria. But worse, you expose them to a sublethal dose. You teach them how to survive the drug.
So you're breeding resistant.
That is how we breed intermediate resistance organisms. So getting that level right, the Goldilocks zone, is critical to preventing the next superbug.
How long are we on these meds? Are we talking days or months?
It varies significantly. A mild impetigo might be 7 days, a severe cellulitis, 14 days. But interestingly, for pressure sores, the text says you treat until the signs of infection, the redness, the fever resolve. You do not keep giving antibiotics until the hole in the skin heals.
Because the hole could take months to close.
Exactly. You can't keep a patient on antibiotics for months. You'll destroy their gut microbiome and breed more resistance. You just want to clean the invasion, then let the body heal the structure on its own timeline.
Synthesizing all of this, the skin really is a dynamic barrier. We tend to ignore it until it fails. But this text paints a picture of a constant standoff.
We do. And the takeaway here is vigilance. SSTIs range from being a minor annoyance to a life threat. And the difference is often how quickly you notice the breach.
And if we had to summarize the red flags,
Yeah.
the signs that say go to the ER now, what are they?
Rapid spread. If you can watch the redness moving, literally seeing expand over hours, that's bad. A foul smell, that's necrosis or anaerobes.
The smell test again.
Smell test. Numbness, that suggests nerve involvement or deep pressure, which is a hallmark of the diabetic foot or necrotizing fasciitis. And systemic signs, if a skin problem is giving you a fever, chills, or low blood pressure, that means the war has moved from the border to the capital city.
That's a great analogy.
One final thought that the text alludes to is the balance of our own microbiome. We spend so much money on antibacterial soaps, trying to sterilize ourselves, but Staph aureus lives on the skin or in the nose of many healthy people perfectly happily.
It's a harmless passenger.
Until there is a crack in the armor, scratch, a bite, a blister, then that harmless passenger becomes a lethal invader. It's not about the bacteria being evil, it's about them being in the wrong place.
It certainly makes you respect a paper cut a little more. Keep the barrier intact, keep it clean, and pay attention to what your skin is telling you. Thanks for listening to this deep dive into skin and soft tissue infections. Wash your hands, watch out for clenched fists, and we'll see you next time.
Stay healthy.